Right. Thanks, Bethany. Welcome, everyone. I'm Don Neese. I'm the Director of Community Engagement with CCTSI, and I'm also Vice Chair for Community in the Department of Family Medicine. And great to see all the names popping up here in the participant list. So glad you were able to make time in your busy schedules to join us today. So today we're going to be talking about what it means to be doing community engagement work during this difficult time of COVID-19 and also related to the other things that have been going on related to Black Lives Matter, et cetera. One of the things that we really like to do, in addition to kind of taking on some of these larger topics, but to make sure that we always revisit our principles around community-based participatory research, health equity, and health disparities. So we'll just do a few introductory slides here around that, and then we'll move straight to our speakers. So community engagement, this is a really nice summary of what this means to us. And really the process of working collaboratively with and through groups of people that are affiliated by geographic proximity, special interests, or similar situations to address issues affecting the well-being of those people. I want to point out in this definition is that this really allows communities to self-define so that we're not imposing that sort of definition on folks. So I think that's a really important piece, and also recognizing that well-being impacts can be impacted by a lot of different issues. So we can go to the next slide. And CBPR, as many of you are familiar with, is an approach that we use in much of our work. And this is a nice definition from the Kellogg Foundation. Collaborative approach to research that equitably involves all partners, recognizes the unique strengths that each brings. We talk a lot about shared expertise. CBPR begins with a research topic of importance to the community. So it comes from community and has the aim of combining knowledge with action and achieving social change. Nice summary there. Next slide. And then lastly, health equity. So health equity, many of you, I'm sure, have probably seen this illustration in various forms, that equality, where everybody's kind of got the same platform that they can stand on, but doesn't take into account the different abilities of people, whereas equity attempts to level that. And I really love the third frame here, which is, let's just take down the freaking fence so that everybody has equal access. So removing obstacles that might get in the way, taking into account powerlessness, power differentials, access to jobs, housing, environment, and healthcare. So thanks. We always think about, when we're engaging with partners in the community, that we have to check our academic credentials before we walk in. Be humble. Remember that our solutions may not be the best solutions for the community, so we want to take time to listen and really walk in asking what the need is. So with that in mind, I think we have a poll question that we're going to put out to the group and get you guys to weigh in here, and hopefully everybody can see that, asking about what stage best correlates with how you're engaging with communities. folks a few minutes to respond. So I don't know if we can display the results just briefly. There we go. Okay, that's pretty cool. A lot of folks already out there doing this work, and a lot of folks thinking about it, thinking about how they can get engaged. That's fantastic. All right, well, it's really my pleasure to introduce our first speaker, Dr. Gordon Duvall. Gordon is very accomplished. He's has his doctorate as a nurse practitioner. He works at the Youth Detention Center in Aurora, and also teaches students in the School of Nursing. And Gordon is involved with a lot of community action groups, and we're very privileged to have Gordon as one of our community research liaisons within our community engagement program at CCTSI. And so Gordon, I will hand things over to you and let you get started.
All right. Thank you, Don. Can everybody hear me? I'm not the most technology right person, so I hope everybody can hear me and everything's right. So as Don said, I'm a community research liaison there with the PAC Council, where my job is really to make sure that research helps the community and does nothing to hurt the community. My position with the Division of Youth Services, I was just recently promoted to the Medical Operations Coordinator. So now I'm over all of the clinics in the juvenile detention and committed centers in the state of Colorado. Previously, I was at Gilliam Youth Services Center, which is the juvenile detention center that serves Denver County. And then I'm also clinical faculty at Platt College of Nursing, which is a private nursing school in Aurora. Next slide, please. So I was asked to talk about COVID and how it's affecting our communities, and especially our communities of color. And so I was having a conversation with the group, and we were talking about the implementation of a vaccine when it finally comes, and thinking about how that's going to affect communities of color, realizing that there's a lack of a lot of stuff within these communities. First and foremost, there's a lack of trust. There's a lack of trust in the medical system. The reason being for past research atrocities, like with the syphilis study that they did at Tuskegee, with the study on the cervical cells of Henrietta Lack. There are things in history that minorities just don't trust the medical system. And so the question becomes, okay, how do we rebuild that trust? And I hope we'll be able to answer that question as we move on. There's also a lack of access to medical care, be it a lack of insurance. And I think the biggie is a lack of concerned providers. And when I say that, I'm saying providers that are actually concerned with the health and well-being of not just the whole population, but even specifically to these communities of color. And I think the problem becomes that there's providers, they don't look like them. And so I think that we're doing not a good job at all in implementing and getting students of color into the medical schools, into the research tracks, so that they can go back and serve their communities. As it stands right now, for the most part, those that are coming into communities of color do not look like those communities, and so automatically there is a lack of trust. And so I think that these communities also need to have knowledge as how to ask the right questions when they do go see a physician, when they do go and access the medical system. I don't think they have really good health literacy. And so lack of knowledge adds to that lack of trust. Next slide. So there have been studies, and a couple of these slides I actually took from a presentation that Kaiser put on for their employees. But studies have shown that racial ethnic minorities, just reiterating the distrust that they have with the medical system. They don't necessarily have very good patient satisfaction with their care, because once again, how can you if the person that's seeing you is just doing that, seeing you, but not really honestly caring for you? And then they have less engagement with healthcare promotion, less likely to seek the preventative screenings that we offer. And so this is just reiterating what I said in the last slide. Next slide, please. So my suggestion, how do you approach the community? I think first and foremost, you have to form relationship. And when I say relationship, I'm not talking about that you know Mrs. Jones and she's married and has 2 kids. I'm talking about really forming a relationship the way that you would with those people that are close to you in your own life. And I think that first and foremost, you have to concentrate on building this relationship far before you can even think about doing research. And so when I say get to know the people, get to know their concerns, get to know the things that make them happy. What do they do for recreation? What are the things that are available in the community? What do the kids do? How are they spiritually inclined? Get to know the people. And I think the biggest and the best way to do this, and I try to do this with community all the time, and that's sitting down and breaking bread with people. And I'm saying sit down, have a meal, eat the things that they eat, become part of their culture, realize what their culture is. That's how you're going to build relationship, and that's how you're going to build the trust that you're going to need to be able to go into these communities and honestly serve them. I suggest also doing a really serious community needs assessment, not looking for and trying to make sure your needs are met, but go into the community with an open mind and do a needs assessment to see what are the needs of the community. What are the things that they're struggling with? What are the things that they need education on? And not just the things that they need, but what are the things that they're doing well already? What is it that you might learn from the community that you might be able to share with other communities and other things in your work? Don't look at it as you're doing something for the community. Look at it as a back and forth. This is a relationship. This is a give and take. And how do we build and support that? And then I think it's also important to decide how will your project benefit the community? Why should they let you come in to start with? I mean, if you're not bringing anything that's going to benefit the community, then why should they let you in? And I think that once you build those relationships, that not only will you be able to benefit the community, but you'll want to benefit the community. And think about it from the needs assessment. What needs will this project or your research, how is that going to satisfy one of the needs that you identified in the needs assessment? Next slide, please. So what's needed most by communities of color? In my talking to the communities that I work with, I've been working with the African leadership group here in town. I've been working with the Center for African American Health, with the Inner City Clinic, and just with churches and the African American community. I think that there's a lack of testing resources, especially early on in this pandemic. The resources were not available in the minority communities. They're doing better now, but I still think that not just testing resources, but education around what the resources are. Education on COVID and other health disparities, I think, is really important. It's important to share what are the numbers? What are the comparisons of their community with other communities? I think that it's really important to sell this. We have to make them want it. And so I think the way that we'll want them, they will want to get the services that we're able to offer, is to be honest with them about what the reality of this virus is, of this pandemic is, and how it's affecting them. Next slide, please. As you can see here in this slide, with the orange being African Americans or Blacks within the community, at every age group, Blacks and Hispanics, which is the lighter colored bar, and the dark colored bar being Caucasians, you can see at every age group that this COVID death rate is affecting minorities more so than it is the Caucasian race. Next slide. This slide also shows how the likelihood, the risk of those dying in different minorities as compared to the Caucasian race. For African Americans, 3.8 times more likely to die from COVID than from their white counterparts. Next slide, please. And I think that it's very important to also look at our Native Americans, because their numbers are staggering as well. What has been publicized is that in the United States, for COVID infections per 100,000, it's right at about 400 individuals per 100,000. The research that I saw for Native Americans ranges anywhere from 0 to 3,300 cases per 100,000, with the average being about 32. But what I did find was that there are some reservations, some groups of Native American people, where per 100,000, some of them are at 500, 800, all the way up to 3,300 people per 100,000, compared to the 400 average for the United States. This group of people is actually having a hard time with this virus. And I don't know for sure what research is doing and what others are doing to go in and service these people, but I don't want this, this group of folks to be left out of your radar, because they are definitely in need. Next slide, please. I also think that youth need to be on your radar as far as looking at resources and doing research. A lot of our youth have missed out on milestones in life, be it graduations or proms. Human beings are communal beings. Staying at home, especially during the time of adolescence and young adulthood, and having to social distance, I believe this is going to have quite the impact on their mental health. And so what are we thinking from a research standpoint and from a services standpoint, going into these communities and really seeing and assessing these young people to see what are the long-term effects going to be on their mental health with just living through this pandemic. My personal prediction is that we're going to be dealing with this for 2 or 3 decades to come. The ramifications from the development and the mental health of these young people that are going through this pandemic today. And what are we going to do as researchers and as the medical community to get ahead of this so that we can actually have things in place to be able to provide services for these people before it becomes a crisis in their life? We already know this is going to happen, so what can we put on the front end to be able to deal with them rather than having to scramble to put something together when the crisis arises? Next slide, please. And so how to help? Like I said, relationship, relationship, relationship. I think it's so important that you have a heartfelt, honest relationship with the people that you'll be working with in communities. Otherwise, why should they let you in? Think about it from your standpoint. Would you let somebody in your life into the very private at times, intimate at times, areas of your life without being in relationship with them? And I would be willing to bet that you would say, no, you would not. So why would you think that you could go into these other people's communities and not being in relationship with them? I think that it's also very important that you do a needs assessment. Don't go in just thinking that these people need what you have to give them. Go in and do a needs assessment and be an honest needs assessment and figure out what really are the needs for this community. And you have to be willing to realize that after a needs assessment, You might, with your knowledge and in the analysis of your assessment, figure out that the community that you're looking at, they might not need, nor want, nor be beneficial for the service or the research that you're trying to bring to them. And you have to be humble enough to be able to back off and say, this is not the place for it, because I have formed a relationship with these people and I don't want to do anything to hurt them or their community or the things that they have going on already. And then once you've done the needs assessment, how are you going to be able to satisfy one of the community's needs? Once again, being honest, is your research, is the project that you're trying to do going to actually benefit the community? And if not, once again, I think you have to be humble enough to back off and step away and say, no, I'm not going to do any harm to this community. And then what is that benefit that you're going to provide for the community? I think it's very important that just because you think it's a benefit, you must also ask the community, is this something that's going to benefit them? I think one of the worst things in the world that we do as the medical profession is going into communities or even a particular patient, telling them what they need, rather than asking them, how is it that I can help you get to where it is that you're trying to go? And so I think that's the way we have to look at it, that we're helping a community be able to reach the goals that they've already set. Now, they might not have any goals set. And so maybe we'll have to facilitate a process of helping them to be able to identify, plan, and meet their goals. And that might be all that we do as researchers. But I think that that's also, if we make it so that the community is the important thing that we're trying to do, that we're trying to support, that we're trying to benefit, then I think if that's the lens that we're working through, then what I'm trying to say, it will definitely happen. And then we want to create and support community. You might go into a community that's totally fragmented, that needs to be brought together to have the support, to realize that there is safety in numbers. There might be distrust in the community that you have to go in and try to build that trust. Whatever it is, you'll find that out in the needs assessment, and then that will guide and lead you as far as what you're going to do next. And then I have to say that it's very important that we need to figure out how to guide and to support the youth that are being affected by this pandemic today. They are going to need it. They are going to be adults soon. And I don't think that as a society that we want people that experience this in their teens, now at that time in their 40s and 50s, still having ramifications and problems from what they went through during this pandemic, especially when we have the technology and the knowledge to know how to support them. The question is, will we have the willpower and the resources to do it? I think that is about my last slide. I believe at the end, we're going to have time for questions.
Thanks so much, Gordon, for those powerful words. Really, really good stuff. And yes, we will have time for questions, discussion. I really would encourage folks to go ahead and put anything you might have as it comes up in your own mind into the chat, and we'll make sure we circle back to those. So it's now my pleasure to introduce Dr. Ricardo Gonzalez-Fisher. Ricardo is has binational roots with a mother who's from the US, father who's from Mexico. Dr. Fischer trained as a physician and a surgeon in Mexico and practiced there for many years. Worked in medical education in Mexico, ran a hospital, and we're fortunate enough to have him now in our own backyard. And he's a member of our PACT Council that guides our community engagement work through CCTSI. And he works very closely with Servicios de la Raza here in the Denver community. And without further ado, I'll have Ricardo go ahead and take us into the next section.
Well, thank you very much for the introduction. And I'm bringing these slides, and I would like to start just showing a lot of numbers there. And remembering that small quote that says that one death is a tragedy, a million deaths are only statistics, and I don't want us to fall into that. Can we have the next slide, please? Yeah. So I'm going to talk during the next 10, 12 minutes about 5 different things. I'm going to talk about our community before COVID-19.
Ricardo, we may have lost you.
Next. Thank you. Well, I will start by saying that what a lot of people know, Hispanics are the largest minority in the United States. In 2014, we were 7.4% of the United States population. That's close to 55 million. We are expected to be close to 1/3 by the year 2060, and this will be 120 million people are going to be from Hispanic origin by then. We all know that, unfortunately, the prevalence of chronic conditions in this population is higher than that for non-Hispanic whites. And we know that these conditions can lead to complications that will have a negative impact on the quality of life and a high mortality risk. We also know that Hispanics are disproportionately affected by poverty, conditions of daily life that are shaped by social and structural position factors such as macroeconomics, cultural values, income, education, occupation, and all the social support systems and healthcare system. And all of these things together will have a negative impact on health. As an example, just talking about something that's really common, 1 out of 4 people in the United States will have their type 2 diabetes undiagnosed. But if we go to see it in our communities, this will be 1 out of 2. Can we have the next slide, please? And just to talk about our diabetes, we will talk that in a survey that we recently did in our Mexican consulate, we saw 780 people in the Ventanilla de Salud, and we found that at least 69% of our families have a family history of type 2 diabetes. Out of those males, 6% of our males and 16% of our females have a history of being having high glucose or being pre-diabetic before this. 79% of our females and 86% of our males were overweight, with obesity in 39% of females and 40% of males. And if we go to measure the circumference of their abdomen, we will find that these numbers are very high. There's nothing, or there's very little that we're doing constantly to prevent this. Can we go to the next slide? We also did another study thanks to funds from the Colorado Cancer Coalition. We were trying to find why our population isn't getting screened for colorectal cancer, but we asked for more questions, and this is what we see. Unfortunately, only 42% of the people we serve have health insurance, 42%. And of those who have health insurance, only 60% have a regular healthcare provider. And of those, only 55% had a routine checkup in the previous year. We know that 1 in 4 had a visit to the dentist in the past year. And before we had COVID-19, 80% of the people would report having 0 to 5 days without good physical health. And 60% of the people that we see every day in the Mexican consulate will have 0 to 5 days without good mental health. So this is the size of the things that we were seeing before COVID-19. Can we have the next one, please? We wanted to know why our community doesn't go to see a doctor. And there's other things that we need to try to understand what's going on in our community. And one of the things is that, of course, people cannot pay for medical care. And I can include in this part that they don't pay for medical care. They are those surprise bills that they don't find easy to pay for. A lot of people don't understand the system. I like this one that people say that I've never been sick, why should I go to a doctor? We have language barriers. And here I have to make emphasis in that people don't like to talk through interpreters when they're talking about medical issues. We have 5% of the people with migratory fear that has been increasing with public charge. And we also have a group of people that prefer to be treated by a traditional healer. And it's very interesting to find out that there's those little traditional healers that take care of people in the Denver metro area. Can I have the next slide, please? Now, community-based organizations have been struggling before COVID-19. We struggle because we have low access to public funds for community services. Another thing that I need to say that is very important is that the current administration started penalizing nonprofits that would provide services to undocumented immigrants. And here I have a big example of this. We used to have a mobile van from Susan G. Komen that would go to the Mexican consulate once a month. And we started by providing free mammograms to 40 or 50 people per month. Starting on this new administration, when they were told that they would not receive funding if they were giving services to undocumented immigrants, we stopped having the free breast screenings for our people. Can I have the next one, please? So here I believe that everybody can agree that screening and health promotion not only prevent disease, but will reduce also other socioeconomical disparities. So one of the things that we were thinking before is that we need to close the gaps so every person can have access to basic health care. Now, this is what we have right now. Health inequalities related to socioeconomic status, cultural background, employment, and being foreign-born or undocumented, as well as aging of this population with undiagnosed chronic conditions will lead to an increase in the burden of disease. And screening and health promotion not only prevent disease, but as we said, will reduce these racial and economic disparities. So this is where we are right now. So if we can have the next slide, and the next slide that I'm showing is COVID-19. COVID-19 is a lot of things, but COVID-19 for us is a magnifying glass that will show us the next slide, please. That health inequalities related to socioeconomic status, well, the same thing that we were saying, only bigger. You can see things that we were seeing before, but they are only bigger right now. Can we have the next slide, please? Now, I want to talk about what our community has been going through during this pandemic and what we've been doing. During closures, our communities continue to serve the population in different ways. We activated a cell phone, a dedicated cell phone that we gave through social media and different conversations to the people who visit the Mexican consulate, so we can receive phone calls for them asking questions. So we have been receiving during the closures between 4 and 5 phone calls every day to refer clients to dental care, medical care, to answer the questions about COVID-19. Our mental health program at Servicios de la Raza moved to give mental health services online to establish clients, and they started to have a waiting list for new clients. Our food bank has been working, getting more donations and having the food pantry delivering food to people who are sick, taking it to their house, or putting it in the transit cars twice a week. So those services have increased. Also, we have a group of people who take care of victims of crime, and that has also been growing for us. Then we had to open again. We opened the Mexican consulate, and we started to do a survey that the Mexican governor asked us to do, and we found that at least 50% of the people who visit the Mexican consulate were losing part of their income because they lost their job or someone in their family lost their job due to COVID-19. Some of those who had a job and had insurance, and remember that we said before that only 42% had insurance, some of those also lost health coverage. And although our people tend to have a solid family support, we found also that 15% of those of our community is requiring help for food, and a large number of them would like to receive some kind of mental health support. Another thing that we did, we started to have a testing center on the clinic next door, and we are now testing people for COVID-19, testing for an antigen, and we can get results in 15 minutes. We started this program 3 weeks ago, and by now we have 275 patients or clients tested, and we have a 5%, more or less 5% rate of positives. We've been doing tracing our cases, and we've been finding little clusters of families who live together who have been infected. Can I have our next slide? Now, yes, as we return to being normal, we are also finding that there's a need for more reliable information and resources for our people. For example, parents don't know if they should return to work. They don't know if they should take their kids to school. They fear bringing COVID-19 to their house if they're with contact with some other people. And this is very important because I believe that community-based participatory research has been playing a very important role right here. And I can tell you that Servicios de la Raza is working with a group of people that the governor is using to give information or to get information from communities. So they approached us to try to discover what kind of messaging they were doing. And of course, they asked us to message and say, well, please go back to the Blackboard, because they were trying to say things like, hey, community, do it for your grandpa or do it for your grandma. And they said, well, this means that the way we would see it is that our people, if I don't have a grandpa or a grandma, then it means that I am not vulnerable, so I am not tied to doing those things. There was another message that was going to talk about the workers, let's do it for the heroes that are in front, and say, well, just remember that I've been telling you complaints of the girl who works at Burger King who doesn't have protective gear. I've been talking to the couple of people, this couple who do the cleaning in the clinic for Children's Hospital, and they don't give them protective gear. And I'm talking with the person who works washing hospital linens, and they tell her, don't worry, they don't have COVID, you don't need things. So if I tell them, let's do it for the frontline workers, they will say, well, what are they doing for us if they're not protecting us? So my question here is, and this is what we told them, if you really want to know what the people want or what the people need, please ask the people. go and use this and ask the people. So can I have the next one? During the first 3 weeks of opening, we screened 500 people, and we found several things that were important. Most of our people are informed about COVID-19. They obtain their information through TV, Univision, Telemundo, Estrella TV, some radio, social media, schools, or the workplace. But if we start to have this informal communication with them, we start to identify that there's a great deal of confusion with contradictory information. People don't understand the need and benefits of using a mask, for example. Some use it because it's mandated. Some use it because it's required to go someplace. Others think that if they wear a mask, they're preventing themselves from getting sick. And just a few understand that they're protecting the rest of the people by using a mask. Also, social distancing has been difficult because of our culture. And people tend to think that if they are wearing a mask, they don't have to social distance. And this is another important. And another thing about testing, they believe that if some people have told us that if they get tested and it is positive, they cannot go to work. So they believe that they can be working if they're not tested. Can I have our next slide, please? Another thing that we found out is that the subcultural messaging is also important for our communities. People tend to trust their comadre, more than what they trust health authorities. And a lot of people will take advantage of this fact. And some of the things that we've been seeing is a constant flow of information of quote unquote natural remedies, diets, juices, miraculous cures for everything, and other things. And well, I'm going to try to go to our next slide. Like, for example, I just want to let you know that what we learned is nothing new. What we learned is that we're just seeing more impact of the social determinants of health. And there's just, and another thing that I've learned is that there's more than social determinants of health. So just to finish this, I'm going to jump these because these are just numbers that we all know. We are affected a lot by this virus. And let's go to the next slide, please. We have a high rate of uninsured people and it's growing. We already talked about this. Let's go to the last one. And I just want to go here that by working with these underserved communities and by being accepted as a member of the Mexican immigrant community in Colorado, I am confident in ending this intervention by thanking Charlene, by thanking Lorenzo, by thanking Montel, because they opened my eyes to community-based participatory research. Thank you very much. I also want to thank the PACT Council for doing all the job and promoting the respect and inclusion of the communities trying to solve community issues. And I will take just a few seconds out of just to tell you what I believe we can do for the future. And I can tell you just on what can be done. And I can tell you that we will not be able to produce sustainable change if we don't promote the United States ratification of the basic human rights treaties and conventions of the international community. This will include a list of agreements on human rights, including International Covenant of Economic, Social, and Cultural Rights, Convention of Elimination of all forms of discrimination against women, for example, or protecting migratory workers. We also have to be aware that the United States is the only country in which healthcare is not a human right. We should also try to move towards those things. And I think that if we change the United States criminal system, we will find out that we are the country who has more imprisoned people than any other country in the world. Also, be careful with what we're doing with immigration. If you look at the news, you will see that there's a lot of children that are still captive in the South or in different parts of the United States. And finally, I think that one of the easy ones is to try to homeless and hungry in the United States. And this is a beautiful, beautiful opinion note that was published in JAMA on June 12th of this year that's called The Moral Determinants of Health. And I think that that's it where we should move on. And I'm sorry that I took a little bit more of my time. Thank you.
All right. Thanks so much, Ricardo. So we're going to move into some questions for both Dr. Duvall and Dr. Gonzalez-Fisher. First question I think could go to either one of you, actually, and it's the question is, how can we make a shift from not just collecting data, but to using existing data that can help spur us to action to meet community needs?
I guess I'll attempt that. I think that especially with not just the state of our society with the pandemic, but the fact that we're really looking at institutional racism and some of the other things that have been going on in our society. I have actually my current boss is doing some research around best practice, because is best practice really the best practice for all communities? And so I think as researchers, we might need to think about that. So I'm not sure that current data is going to actually be beneficial when we're looking at individual communities, because we have to understand where did that data come from and how was it collected? And was there some inequalities in even reporting that data? I think we're going to have to question everything that we have trusted up to this point, because we're finally coming to the realization that a lot of the stuff that we have was put together bogusly. And so going into the community, you have to be willing to say that, I don't know for sure if this is the best thing. And so let us look at it together and decide if it is. And so I would say everything that we know for sure that we have said is best practice, especially going into work with communities of color, needs to be relooked at, because is it really best practice for those communities?
Excellent points. Ricardo, anything to add?
No, I couldn't agree less. I think that one of the things that we've been doing for a long, long time, and I include myself when I was doing the research part from the academician point of view, is that we ask questions that we want to answer, but we are not asking community what they want to know. And we sometimes believe that we have the right answer to the right question, but maybe it's something that community has never thought about, and maybe it's not important for them. So this is what I would think.
Yeah, I think.
And asking the question.
Yeah, this feeds in a little bit to a couple of the other questions that had to do with needs assessments, and how are those best done? Is that surveys, town halls, discussions? Any thoughts about that?
I guess I'll jump on that again since I brought up the needs assessment. I think it's all of that and more. So yes, there have been some tools that have been developed to do needs assessments. But once again, is that the best way? I think a relationship with the people you'll be dealing with is the best way to do a needs assessment. Really get to know them and be in relationship with them so that you can figure out not only what their needs are, but what do they perceive their needs to be. And perhaps you could, in your assessment, come up with maybe what some other needs might be. With my nursing students, we do what when I have them do a needs assessment, just for example, I've had them come into the detention center and do, the project was to put on a health fair for the youth, which went from being a health fair to more of a health resource fair, because after doing a needs assessment, and the needs assessment was basically a short survey that they sat down and didn't let the kids fill out, but sat down and had more of an interview with the youth so that they could really delve into what it is that they needed. And what they found was that for the most part, kids are healthy. We knew that. But what they also found was that they needed help removing tattoos. They needed help getting out of gangs. They needed help finding a career and having some job development. And so the health fair that I envisioned would be checking blood pressures and telling you about your dental stuff and how to eat right, turned into a resource fair where I had people there that organizations that helped them get out of gangs, tattoo parlors that actually would remove tattoos for a low cost. Job Corps came to give them ideas as far as how to get a career when they finally left out of here. But we would have never known that had we didn't sit down and do a survey and talk to the youth as far as what they needed, what were their concerns. And so once again, the needs assessment, I don't think is a quote unquote tool that's a universal fit that we can just go out and have a community fill out the survey. No, it's about sitting down, having relationship, being able to get to know these people so that you know and feel what their needs are. And so I use the word needs assessment as if it was this magic tool that can be done. I think it's more of a process than actually an item or a tool that you can use.
That's great, thanks. Anything else to add, Ricardo?
I would add that maybe, well, what I've seen, but this is just on the community that I see, people are tired of being surveyed for everything. People, I mean, here's a survey, help me fill it up. They'll fill up the first page and leave it there. They will just answer something. They don't like surveys. And I would think that once they trust you, they will come and talk to you. And those are the things you have to listen. More informal communication, but paying a lot of attention. This is what I would say.
Yeah, great. So I think this feeds into one of the next kinds of questions here that we've had, and this was actually something that was submitted during our with our RSVPs. But it's, you know, you guys have talked a lot about the importance of relationships and forming those relationships with communities. How do you think that works now that we're doing all of this virtually? Have you guys come up with any tips or ways? And I think I also want to work in, if you have any comments about, you know, how trusted partners can help facilitate that.
There was a survey that was done, talking about a survey that was done at Servicios de la Raza with the people who we are caring for. And one of the things that was most important for us now that we're working remotely is that 71% of the people said they would prefer a phone call than a text message or another thing. But this is biased because you will get a phone call from someone you know. When I started to make phone calls to follow up with the people I was screening for type 2 diabetes and we were referred to the doctor, they would not answer the phone unless I would send them my picture and saying, I'm going to call you right now because, and then they would answer the phone because they don't trust people just like that. I can talk about the communities that I serve, and I can tell you that they feel a lot of pressure, a lot of things going around that they don't want to engage in a relationship with someone they don't know. So I think that our liaisons are very good. I think that we need to promote more liaisons in different small groups. And this is the way I would try to solve this.
All right.
And I also agree with Ricardo, but I also got to realize that a lot of the community does not have access to the technology that we're used to from the university and from the work that a lot of the researchers do. And so we have to go and meet the people where the people are, what they're doing. I agree with you, Ricardo, that a phone call is probably better, you know, with the limited contact that we can have with folks. we have to figure out a way to form relationship. And COVID has definitely made that difficult to do. But I believe that almost all of you in the audience, it was difficult to get the degrees that you have as well, but you figured out how to do it. And so let's figure out how to do it. If it's important, we can do it.
Awesome. All right, so we have one more poll that we want to put up in front of folks. So I'll have Jordan post that and give folks a moment to respond to that. And while folks are responding, I want to thank again Gordon, Dr. Duvall, and Ricardo, Dr. Gonzalez-Fisher for your comments today. They've been inspiring and enlightening, and I want to thank everyone for showing up and being a part of this. I will also say that these sessions are recorded, as well as we make the slides available. Our slides for today, there were some I skipped over that have links to resources that we've created within CCTSI for COVID-related materials. So when those are made available, I'd encourage you to pull those up and have a look at those, and maybe you'll find them to be useful in your work with your own communities that you're working with. And lastly, just a plug for reminding folks that we do have a new set of community research guidelines that have been posted, and a process for you to get re-engaged with your community off-campus research work, and that is posted and available as well. And if there are questions about that process, don't hesitate to reach out. All right. Well, with that, we are a minute away from the top of the hour. Thank you again, everyone. And we'll look forward to seeing you again in October.
Thank you. Thank you very much for organizing this.
Thank you, Ricardo.
Yeah, that was good. Hopefully, everybody else thought so.
That was really good.
Bye-bye.
Great job, Gordon. Thank you so much.